So hi everyone, the 46 attendees that are here currently. So before starting the webinar officially, I'm going to just go through some housekeeping notes for this webinar. The first one is about the video recording. So as long as you know, we are just recording the whole webinar. And so if for any reason you don't want to be in the video recording that's going to be published on YouTube and other social media, you can just turn your webcam off. And yep, that's it. And also another thing is about the microphone and your video. We just request you to turn off your microphone during other speakers' talks in order to just make sure that everything is going to just continue in an organized way. But you can turn your webcam on so we can just see you. And the next part is about the question and answer and the discussion part that we would like to ask you to raise your hand when you want to ask a question or just engage in the discussion. Another thing is about the chat space that you may see down there. You can just type your questions, your comments, the links that you may find may be useful for this webinar, so everyone can see that. And the questions will be covered one by one at the end of the webinar. And yep, and that's it. So hope you have a great webinar. And yeah, you can just and if you have any questions or problems with your the GoToMeeting platform, there are two organizers in the session. It's me and Nikki, so you can send us private messages in the chat space, and then we can try to figure it out.
Thank you, Parnin. All right, Vic, do you want to make a start?
Yeah, let's make a start. Good afternoon, good evening, and a very early good day from your webinar host here in Australia. We didn't work that out well, did we, Antonio? We really should have thought about a different time. But welcome everyone to the second webinar in the ISAM Neuroscience Interest Group series. I'm Victoria Manning. I'm an Associate Professor in Addictions at Monash, Head of Research at Turning Point, which is an addiction treatment training and research centre in Melbourne. And I'm one of the leads for the cognitive training subgroup of the Neuroscience Interest Group, along with David Pennington, who we'll be hearing from a bit later. And so Antonio is also helping to chair this session. And I'm sure you both know Antonio and Hamid very well, but I'll introduce them both properly later. I do apologise that my camera's not working, but I'm as long as everybody can hear me, is that the case? Yep, Antonio, can people hear me?
Yep.
Yep, great. Can I do the share screen then? Possible. I'm really excited about today's webinar, and we'll be hearing from some of the world leaders in different cognitive training approaches, including cognitive remediation or rehabilitation, cognitive bias modification, working memory, and goal management training. And so we'll be hearing what we really know about those interventions so far, some of the challenges and opportunities, some priority research questions, and the potential to share protocols, programs, and other resources to foster collaboration. And we're also very fortunate to have Dr. Aklin from NIDA to share with us the funding structure, priorities, and opportunities from a NIDA perspective. Let's go to this one here. I'm sorry, I'm just trying to share my screen. I'm not sure if that's working. Yeah. Is that working? Yeah. Great, thanks. In terms of the agenda, after hearing from the speakers, Antonio will lead a discussion on how we shape future research efforts and advance best practice standards. But just before I go, I introduce the speakers, I thought it'd be helpful to give a brief background or sort of context to the objectives of the webinar and of this subgroup more broadly. So one of the key objectives through its international network of clinicians and researchers is to aim to bridge the gap between science and practice. We know that despite wide recognition of altered brain structures and functions underpinning addictive behaviours, clinicians rarely incorporate neuroscience-informed approaches into their practice. The first initiative of the webinar was then to write a consensus paper summarising the priorities and strategies needed to achieve this, and the resulting roadmap paper was published at the end of last year in Frontiers Psychiatry. And so for the cognitive training section of the paper, we took a close look at individual studies in the literature where most research had been conducted. We focused on drug and alcohol studies primarily, and we also focused on clinical samples, but we did include studies where participants met criteria for substance use disorders in the absence of treatment studies. And we essentially mapped out through a series of tables whether the cognitive training improved the targeted mechanism and whether it impacted on substance use outcomes. And if that's the case, the cells are coded green. If the mechanism was not successfully targeted or substance use was unchanged, the cells are coded a kind of orangey red colour. And if they were not even assessed, they're coded yellow. So with cognitive training or cognitive remediation, which is often at least partially group-based and typically targeting multiple cognitive functions such as attention, memory, executive functioning and social cognition, and with the broader aim of improving functional outcomes, as you might expect, studies generally showed improvements on at least one or two domains. However, only 2 studies have shown reduced substance use or improved substance use outcomes, although some others have reported improved quality of life. With working memory training, about half of studies have shown improved working memory or near transfer effects, with some showing improved delay discounting or episodic future thinking, which some consider to be far transfer effects. However, whilst more studies have assessed substance use outcomes here, only one has really shown a significant reduction, which was in alcohol in a non-clinical sample of problem drinkers. And given the intensity of a lot of the working memory programs, with things like CogMed requiring 25 plus days, there's really a need for more research on clinical populations, which David may talk to later. With inhibitory control training, which is largely single session, stimulus response go, no-go, stop signal training paradigms, there's been more emphasis on measuring substance use outcomes, but less on whether or not it targets, reduces impulsivity. And several studies have reported significant reductions in alcohol use. However, again, this is largely limited to non-clinical samples. And there's one recent addition to the literature, which is a feasibility and acceptability study of inhibitory control training for people being treated for cocaine use disorders alongside contingency management, where training improved inhibitory control, both with cocaine and neutral images, but it didn't change cocaine use. And there's also been 2 fairly recent meta-analyses concluding that ICT leads to small but robust reductions in alcohol use immediately after training. And finally, with CBM, there's many studies on clinical populations, and these typically deliver between 4 and 12 sessions of the CBM training. The top half of this table shows those studies that have targeted approach bias, and the bottom half those targeting attentional bias. So you can see for approach bias, which has been mostly in alcohol populations, when measured, there does seem to be evidence of reduced approach bias and consistent reductions in alcohol use up to 1 year later, with 1 or 2 exceptions. Whereas the literature on attentional bias modification is more variable. There's been several studies that have failed to show a reduction in attentional bias, and only a handful have really shown reductions in drinking or relapse. One that did was showed reduced heroin in a sample of methadone maintenance treatment patients, and recently we've seen some negative findings following attentional bias modification in cocaine and methamphetamine patients. So the consensus paper concluded that we need more studies on clinical populations, and we need more consistent assessment of both the mechanism in terms of cognitive markers, but also their impact on substance use outcomes. And if we really want to sort of increase the appeal and get the necessary buy-in from clinicians, we need to consistently measure and hopefully demonstrate meaningful change for patients, be that abstinence, reduced consumption, or reduced craving. It's also hard to get a sense of what's really working for whom and under what circumstances, and to identify the neurocognitive phenotypes because of the heterogeneity of study designs, as always, with different treatment settings, different populations, intervention protocols, the absence of a standard intervention dose in terms of the number of sessions or duration of training, variations in primary outcome measures as well complicates the picture. And as such, the NIG paper recommends a commitment to a priori published protocols and standardizing designs, interventions and procedures where possible. But really, to reduce this lag in translating findings into clinical practice, we need more robust evidence, and that includes the replication of these promising pilot studies on which a lot of this is based, with larger samples and active placebo control RCTs. We also need to think about evaluating how we implement these cognitive training interventions into clinical practice. And we need to address things like poor adherence. We need to measure the cost effectiveness of these interventions and use patient-reported outcome measures. And finally, we also recognise the need to explore synergistic approaches. So we might think about combining interventions targeting, say, top-down and bottom-up systems, but also staggered or sort of recovery staged approaches. So we might think about, for example, dampening cue reactivity using CBM, for example, early on in treatment, and then strengthening cognitive control, perhaps using ICT later on in treatment, prior to engaging in more intensive but ecologically valid training, such as goal management training. So hopefully that's given you a sense of where the NIG aims to make its mark, I guess, and to advance the field and a sense of our current thinking. So now let's move on to hear from the experts in these interventions. So I think, Will, are you able to share your screen now, please? And while you're doing that, I should just introduce Will. So Dr. Will Aklin joined NIDA in 2008. He's the director of the Behavioural Therapy Development Programme, which supports stage 1 to 3 research. So that's treatment generation, refinement and efficacy. Will has established clinical and research experience in behavioural and cognitive behavioural treatment for substance dependence, adaptive brief interventions and adherence trials. Will is a sought-after leader across NIH and co-leads several NIH Common Fund initiatives, including Science of Behaviour Change, as well as partnerships with the Food and Drug Administration on digital therapeutics and device-based treatments for substance use disorders. Welcome, Will.
Great, thank you very much, and thank you for having me. Is my audio okay, and do you have access to my screen?
We do.
Excellent.
That's great.
Excellent. Fantastic. All right, so let me go ahead. Well, thank you, everyone. I direct the Behavior Therapies Development Program, and I'm grateful and thankful for being able to present to you all priorities and opportunities within the National Institute on Drug Abuse. So just a little bit of context behind the Division of Therapeutics and Medical Consequences, where my program sits. In 1989, Congress mandated the Medications Development Program within NIDA. So this was one of the only congressionally mandated programs within NIDA. In 1990, NIDA created the Medication Development Division, now which is called the Division of Therapeutics and Medical Consequences, to realize these goals. And the mission was twofold. One was to use science as a vehicle for improving the management of drug addiction, and also to emphasize the identification, evaluation, and development of safe and effective medications, as well as biologics, to treat substance use disorders. And in 2015, the Behavioral Treatment Development Program moved to the Division of Therapeutics and Medical Consequences, where my program has moved to. And now the pharmacological and non-pharmacological treatments have a single home. So that's kind of the context behind the Behavioral Therapy Development Program. So the goals of the program are threefold. First is to produce efficacious behavioral treatments for substance use disorders. Also to produce treatments that are implementable and self-sustaining. We really want to infuse resources into treatments that can sustain itself beyond the course of funding. So we really place a premium on applications that really get at producing treatments that are implementable and self-sustaining. And thirdly is to develop optimal behavioral strategies to promote medication and substance use treatment adherence. So, in short, the priority research areas include emphasizing efficacy across a range of research questions. And one is mechanism of action, technology-based treatments, the combination of medication and behavioral treatments, as well as neuromodulation. Other drug classes that we are very much prioritizing at right now are opioid use disorder. So that includes the range of medications development and behavioral and cognitive treatment development, overdose reversal and link to treatment, and also pain management, but also with a focus on opioid sparing. So such that patients can reduce their level of opioid use, but achieve maximum efficacy from a behavioral intervention. Nicotine, as well as tobacco use disorder. And as you well know, there are no FDA-approved therapeutics for cocaine use disorder, methamphetamine, and cannabis use disorder. So those are also priority areas for us. So the overarching framework that guides the research questions really espouses an experimental medicine approach. And essentially, the question that the experimental medicine approach really seeks at is, what are the processes and mechanisms that drive behavior change? And really it answers, or requires rather, three questions for this type of framework. First is the hypothesis about targets and mechanisms of change that drive behavior. So what are the proposed targets that drive behavior? The experimental methods for engaging the target. So we really want to ensure that there are valid measures of really engaging or measuring engagement in those targets. So we certainly encourage multiple levels of analysis, so behavioral assessments, as well as cognitive and biological assessment. So looking at a range of assessments to really ensuring a valid assessment of target engagement. So here, this is just a simple, I just wanted to kind of boil it down to the essential elements here. In the blue box, you will see the intervention and the outcome leading to that from that intervention. So that is the traditional efficacy testing, as we well know. And we really want to encourage understanding the putative targets that really factor into the change of those behaviors. So was the target engaged, getting a sense of that putative target? I used delayed discounting, for example, that Victoria mentioned in her opening remarks. And is the target valid? So really getting at not only the behavior change, but also the how and why the intervention works. And I think to that end, we can certainly increase the optimization as well as customization of interventions in a way that we can boil interventions to the essential elements, but in a systematic and careful way by looking at those putative targets. This is just an example, a high-level example of some targets that we do know already. Looking at the stress model and looking at saliency, for example, you can see that the interference, for example, with contingency management, the intervention and the target interfere with drug reinforcing effects. And here you can see in the middle section lists several targets that we know really where the road begins, and using interventions to really tap into those targets and improving on treatments is really where I think we can move in terms of priorities and really move into improving treatments as we have them. So again, this is just a listing of some sample targets that we have and treatments that correspond with them. So why is this important? The study of mechanistic treatments, really, I think there are two important aspects to this. And one is that it can boost the treatment efficacy by focusing on the most potent aspects of the treatment itself, and also increase implementation such that it can really pare down the treatments to their essential elements, but again, in a careful way, doing it systematically. So the second area is novel behavioral targets. As Victoria mentioned in her remarks, there are novel behavioral targets that play a significant role in the prognosis of treatment and relapse, for example. Impulsivity, delayed discounting, to name a couple. Targeting working memory has been found to decrease delayed discounting in some studies. And again, targeting can be measured. These targets can be measured at multiple levels of analysis and really getting a comprehensive picture of the variables that we're trying to change in terms of treatment outcomes. Develop and test novel treatments, modules, and/or adjuncts that can specifically impact these targets are a high priority. And also, given the specificity of the targeted treatments, there are possible implications for precision medicine. Another high-level area is the integration of technology-based or technology-enhanced treatments. Technology has surely taken a huge stance in terms of the level of interventions that include some aspect of technology. And there are a number of benefits that these technological treatments have. And again, I mean, the flexibility, the way of delivering the interventions reliably is another, the confidentiality aspects that many patients express as a positive. But I think there are a number of ways in which technology may help treatments. One is to maintain the potency. And again, that aspect of implementation and sustainability of the intervention is paramount. And I think there is some advantages that technology enhanced interventions provide. I will say that there have been a number of efforts that focus on the development of these technologies. However, we really want to move beyond the development and more in line of the clinical validation of these types of technologies, because the clinical validation has really lagged behind the development. I mean, if you go into the marketplace, you can likely see hundreds of touted digital solutions for behavior. So we really place a premium on applications that really seek to understand the clinical validate or seek to really examine the clinical validation of these types of technologies. So one concrete example is the first FDA authorized digital therapeutic that was for paired therapeutics. NIDA funded the studies that really led to the first authorized digital therapeutic by the FDA. This is to be used in conjunction to outpatient treatment for substance use disorders, really cover a span of substances, drug classes here. That is something that we really value, that authorized pathway, that regulatory pathway that really separates those applications that have really undergone rigor, reproducibility, but also it really gives another level of I would say, it rises above where the kind of standard applications have gone. Given that level of approval that I think the FDA would provide, and such that this would be more in line of a high level approval. So that is something that a pathway that we encourage grantees to consider when evaluating these digital therapeutics. The combination of medication and behavioral therapies is another high priority area. So really aligning the mechanism of action of medications with those behavioral therapies represents a promising area. Also looking at the synergistic effects between the medication and behavior therapy and the extent to which they interact. NIDA has also, our division of therapeutics has been very active and funded the contract for the PK and human factor studies for the nasal Narcan, which was approved in 2015 by the FDA. And so within the context of behavioral treatment and cognitive treatment development, an effective behavioral treatment to improve outcomes of medications is certainly a high priority area. For example, opioid use disorder and overdose reversal. So being housed within the division of therapeutics, so really including the medication development aspects, the behavioral is certainly not only complementary, but I think it's integral in terms of ensuring that we can improve those outcomes of medications. Neuromodulation, this was the last priority area, neuromodulation and behavior therapies. And this is not in any order. These are all pillars that we see as high priorities. So as you well know, of this group, a growing number of studies involve neuromodulation devices to test efficacy for substance use disorders. We know that there have been studies that show activity in neural networks or brain regions. And there are some examples of FDA-approved devices, one for DBS for Parkinson's disease, for example, RTMS for major depression. And so a priority area for us is to examine the interactions with devices and behavior therapies to examine the timing, the extent, and the cumulative effects of these devices. So in summary, NIDA supports research that emphasizes an experimental medicine approach to develop and optimize treatments across a number of priority areas involving looking at novel targets, integration of technology and devices. Toward this end, I think the targeted treatments that really are self-sustainable is what we're going for, is what we're prioritizing. And this is really the most impactful in terms of a public health impact. And so we highly encourage applicants, I highly encourage anyone who has an idea to reach out and certainly get a sense of where these priorities and how these priorities fit into your line of research. So I just wanted to highlight a couple funding opportunity announcement that might be germane to this group in particular. I highlighted some medication development opportunities that could be relevant, but I wanted to point you to the last two, the Behavioral and Integrative Treatment Development Program that has an R01 and an R34 mechanism. The max dollar amount per year for the R01 is $500,000 per year, whereas the R34 is a 3-year mechanism, which spans $450K total for that 3-year project. And we also have a device-based treatment for substance use disorder funding opportunity announcement, which is a phased award, is a UG3, UH3 mechanism. The UG3 is 2 years, and that really leads into the UH3 part of the study, which is a 3-year mechanism. So these are funding opportunity mechanisms that we hope that you would explore and really think about your research ideas and how NIDA can really help to realize those ideas. So I will end there, and if there's time for questions, I will be happy to answer those questions. Thank you.
I will, in the meantime, I would like to.
Are we allowed to ask questions or suggestions?
Absolutely, go for it.
Oh, hi, this is Jag. Will,
Jag?
This is an excellent presentation.
Thank you, dear
maybe you can brief everybody, if at all you have funded or funding any COVID-related research for substance abusing populations under the conditions.
Yeah, great question, and thank you, Jag, for that. Yes, we are. There are supplement opportunities currently to existing projects that one might have that really answer the question of the intersection between COVID and substance use disorder. So there are currently available, and the good thing about those supplements is that they're looking at urgent supplements. So those are rolling admissions, rolling review cycles. So you need not submit it and wait several rounds for it to be reviewed. This is a rolling admission in terms of review. So that's something that I encourage people to take advantage of if you have an existing project that you can answer a COVID-related question. So that's something that is worthwhile to think
Okay,
about.
That's good. I think this is I think for my colleagues, ISAM colleagues who are attending this webinar, is for them to connect with Will. He's an outstanding program director. He will direct you further to help you guide you in presenting your proposals to NIH for funding. So that's a good idea. Good. Thank you. Thank you, Will.
Sure.
Yeah.
We probably have time for another question if there is someone in the audience that wants to go for it. I would, thank you very much for the presentation, Will. It was super clear and super relevant. Could you comment on the role of cognitive training and remediation more specifically within these priorities? And in your experience, what are the challenges that normally applications revolving cognitive training and remediation face in the review process?
So I should have mentioned that I use the behavioral and cognitive and integrative approaches interchangeably. And so we certainly encourage any application that has a really clear hypothesis about the mechanism of action, clear endpoint. So we really emphasize those types of aspects to any study that we fund. I also would say that where I've seen some projects not do as well, and I put that lightly, is that not having adequate comparators, if you're doing a neuromodulatory study, for example, not having an adequate sham, for example. So the control is something that studies that have not gone on to do well really lack in that aspect. So more in terms of the execution of the project, that is really where the emphasis. So the approach, I would say the approach and how the study is designed is really where I would say I would place a premium on in terms of focusing and making sure that that's well designed in that way.
Fantastic. Thank you. Yeah, that's really, really helpful. Music to our ears, I think. We're always interested in targeting, mechanisms and looking at interventions that are sustainable and that can, pragmatic to implement into clinical practice. We will definitely be looking into those. Thank you, Will.
You bet. Happy to help.
Thank you. And just my last question is, some of those last two that you identified, are they open for international collaborations or presumably partnering with a US institution?
Yes, definitely. It is open to international collaborations. Absolutely.
Fantastic. Thank you. Okay, we will move on then to our next speaker, which is Professor Reinout Wiers. He's a professor of developmental psychopathology at the University of Amsterdam. He's internationally known for his work assessing and changing implicit cognitive processes in addiction. He's published over 300 international papers, attracting more than 25,000 citations, and has written numerous books and book chapters. He's received the prestigious VIDI and VICI research grants from the Dutch National Science Foundation and is currently a senior editor at Addiction, the #1 ranked journal in the field of substance abuse. Hello.
Do you hear me? I think I was muted before,
yeah.
But okay, good. And you can see the screen? Can you see the screen as well?
Not yet.
I should put the share button, I guess. Now?
Yep.
Okay, good. Excellent.
Thanks.
Well, thank you, Victoria. And happy to be here in the evening, but it's still light here in Europe. I'll talk about cognitive bias modification, current state of affairs, and some future directions. I'll do events. Here we go. Little bit about addiction and biased decision making, then CBM, ways forward, etc. So, what are we talking about when we talk about cognitive biases? These are biased patterns of information processing, and of course, there can be different types of processing: attention, memory, action tendencies. And we know from measurement studies that they have unique prediction of behavior after controlling for explicit measures. So here we are, more appropriate on this side than in Australia, I guess, at this time. But so attention would be, where do you look? Memory, what's your first association? Action tendency, do you want to go for that beer or avoid it? Okay, so now we go to cognitive bias modification. Here's a little taxonomy that I published a couple of years ago in a commentary on a working memory training paper from Warren Bickel's group. And actually the next talk by Pennington will be about this topic. But I think it's important to have a clear division of these two types of training. And in cognitive bias modification, you always have addiction-relevant cues, whereas the other arm for me is training of general abilities, so without those cues. So in my taxonomy, the selective inhibition that you showed earlier, because it's you train people to selectively inhibit to alcohol cues, whatever substance, would actually fall under cognitive bias modification, and it has also been shown that it has effects on memory associations and actually no effects on general inhibition. All righty. Oops, that goes too fast. So cognitive bias modification came about because the background is that cognitive biases had been related to a lot of forms of psychopathology and health problems already in the 1990s, both cross-sectionally and prospectively. But the key driver here was assessment of causal role. So the idea behind this originally was to directly change a bias, try that, and then show, does this affect the relevant behavior, yes or no? So it's really a test of causality. So those are proof of principle studies. And then, of course, if you find something, then the next step is to go to the clinic, as already told by Will. Just to give you some idea about this type, probably all of you know the attentional bias assessment.probe, very well known, works nicely for modification, terrible for assessment, low reliability. But Colin McLeod, who devised the original, actually did develop a much better task for assessment, the dual probe task. So the idea of if you move from assessment to training and cognitive bias modification is what people typically do is you get one of those assessment tasks like this dot probe. And then if you assess it, then your reaction is you have to actually indicate where the dots are. And then if you are consistently faster when they replace the alcohol than the non-alcohol, you have an attentional bias for alcohol. And then, of course, you can do that because half of the time the dots are behind the alcohol and half the time behind the non-alcohol. So that's assessment. But in training, you then start to manipulate this. And then in one group, for example, you have the dots all the time behind the alcohol. So you train them toward alcohol. And in the other group, on the other side. Obviously, that's only in a proof of principle study, for example, in socially drinking students, and not in a clinical group. That's really a different phase of intervention development, as Will already explained in the last talk. So when you do these proof of principle studies, here's an example, early study we did. We had actually quite heavy drinking students, and then one group was trained away from alcohol, one session, and then the other group kept on doing 50-50. So because they were already drinking quite heavily, we didn't do training toward. So what we found was an effect. So this is the attentional bias, a negative bias after training. So that means they now tend to direct their attention toward the non-alcohol, so that's good. But it was only significant for the trained pictures and not for new pictures, so lack of generalization. And that's really the general outcome of a number of these proof of principle studies that have been done. So then the question is, of course, because you did see that there was also for the untrained pictures some movement in the right direction. So the question is, what happens if you do multiple sessions? Well, then you actually get promising effects. So this was the first clinical study that we did, small study, only 40 people with alcohol use disorder. Half of them were trained away from alcohol. The other did a sham test. And what you see is that only in the trained group, also for untrained pictures now, you get a negative attentional bias. So they learn to turn their attention away from alcohol toward non-alcohol. And there's actually a tendency in the control group to increase their attentional bias. Now, I wouldn't place too much emphasis on this in a small study with our replication, but actually the last study that I'll show you, we replicated the same finding in a very big sample. So if you don't train, the default is that people's attentional bias for alcohol increases, and that some studies have shown actually predicts relapse. So for that reason, it's a good idea to try to retrain them. And we had indications of clinically positive effects here in this first small study. Now I move to the second, action tendency training or approach bias modification, as Victoria already introduced. I thought I'll show you a little bit how we do that. So basically same logic. I first show you briefly how we assess and then how we change. So we developed this task where you react to the format of a picture. For example, push the joystick toward landscape pictures and pull when it's portrait. And when you pull the joystick, you get this approach feeling. That's the zoom effect. And when you push, there's this. And then what you see in this slide is that the heavy drinkers have a tendency to approach, actually moderated by the OPERM1 gene, also related to craving. And light drinkers, if anything, have more of a tendency to avoid. So that's nice. So then we thought, well, can we actually also change this? So this is a proof of principle study, first study in students. Now we only had social hazardously drinking students, not problem drinkers. So we trained half toward alcohol and half away. And we actually did find effects on untrained pictures already in a single session, and even to a different task, the implicit association test, and to behavior in a taste test. So that was very cool. And then we thought, well, let's make this important jump to the clinical field. And by then I'd started working with a group in Germany. This is the clinic from Johannes Lindenmayer, the Lindau Clinic, not too far from Berlin. And there, big clinic, we could test many people with an alcohol use disorder. So they were randomized to two training conditions. The one was relevant training, so we told people to push alcohol away. The other was irrelevant training, so they just pushed in reactance to the format of the picture, but always pushed alcohol away. One was 50-50 control and one was no training. Strong effects, we found generalization to the IIT again. So what you see here, the blue bars, people have a tendency to associate alcohol with approach, which doesn't change if you don't train, but it changes to alcohol avoidance associations if you do train. And this had an effect on relapse a year later, 13% less relapse, 1 year after treatment discharge. We did a replication study, and now we also looked at moderation and mediation. I realized this is exactly the scheme that Will showed in the previous picture. So we actually could show that the 1 year treatment outcome, now 9 years less relapse, was mediated by the change in alcohol approach bias. And there was also moderated mediation. So people with a stronger approach bias actually have do better in this type of training. Then Victoria, our host, did a first independent replication. It's a small study, but interesting results when you train during detox. And there's a recent large replication by the same group, which replicates this effect. So it might work maybe better, we don't know. There's a real need for a direct comparison between training during relapse or after relapse, as we do in Germany. Then neural effects of cognitive bias modification. This is my far cousin, actually, Corinne de Wiers. We share the gene for alcohol research. And she independently went to alcohol research and is now a colleague of Will at NIDA. Here in her PhD, she looked at neuroimaging in addiction, and we joined forces with the group of researchers from the Lindau Clinic, and her PhD team, and looked at effects of CBM on cue reactivity in the scanner. And what you see is reduced cue reactivity in the amygdala after CBM compared to placebo training, so with the exact same stimuli. She also looked at approach bias, but if you have time, I can't show you. Medial prefrontal cortex. And then the last study that we did in this wonderful clinic, we had more than 1,400 patients, ran for a couple of years, and there we combined these two, so approach bias and attentional bias retraining, 6 sessions or 3 of each, and then every placebo condition or nothing. And as you can see, again, all sorts of training do better than either no training or placebo training. There was the combined training didn't do it better. That's what we expected. There was no significant difference between every active condition or between the two control conditions. But we think it was too little, because by now we know the optimum on average is 6 sessions of training. So now, after 3 positive clinical trials, this approach-wise modification is now part of treatment as usual in the clinic. And it's also advised in Germany as an add-on to treatment of alcohol use disorders. So, is it effective? We thought it was, and then there was this early meta-analysis by Chris Day et al., which concluded that there are serious doubts on the clinical utility of CBM interventions for addictions. So, what's going on? Well, this is a classical case of combining apples and oranges, because most of the studies were experimental studies, so really in a different phase of the experimental medicine approach, with students who were not motivated to change, and the few randomized clinical trials actually all had positive effects. It's a paper outlining and reviewing all this in the Journal of Studies on Alcohol and Drugs, What's in the Trial. So here, it's the crucial distinction, lab studies or proof of principle studies. Phase 1 in experimental, you try to establish causality, typically students who drink but don't want to change their behavior. They participate for money or free beer. And what you find in this type of studies is small temporary effects if the bias is changed. Then the clinical trials, it's an addition to the treatment in patients. They're motivated to change. The goal is typically abstinence, and there's consistent add-on effects. It's interesting in between category when you do online RCTs with volunteers who have a problem. They are motivated, but they typically don't want to abstain. They choose their own goal. They want to reduce, and they do, no matter which condition they are. All right, so then we thought we had a review, but maybe it's also good to do this more systematically. So we have a Bayesian meta-analysis because there's not so many clinical studies. And we find indeed confirmation of significant effect on the bias and also on relapse, but not on reduced use. And that's probably because of these internet trials where people choose their own goal. So in conclusion, CBM appears to work in alcohol use disorders when people are motivated to change and have an abstinence goal. Some indications of moderators, strong curativity, strong bias, strong impulsivity. It's no panacea for your binge drinking students who are not motivated to change. Other substances less clear as yet. And it really shouldn't be seen as an alternative to CBT. Some people have, I think, that also explain some of the hostile reactions, but really as an adjunct. And it may help to automatize choice behavior in addiction and other psychopathology. And that's what I see as the way forward to improve. Of course, you can make it more playful, but actually we learned that motivation to train is really not the same thing as motivation to change. They're really different things. So I don't really think that's the key. We did a couple of studies where we added neurostimulation. Didn't really make it much more efficacious.
1 more minute, Reinout.
Yep.
Okay.
But really conceptually, I think most interesting is where you more personalize alternative goals, especially in other addictions. Because for alcohol, there's this natural non-alcoholic drinks, which you can take, but what is non-smoking? So you should personalize running or gardening or calling your mom for someone else. It's related to a goal-driven behavior account. And you also, importantly, add a consequence. So if you add that all up, you get ABC training, which is our latest idea on optimizing cognitive bias modification, and just impress now this week, really. Where the idea is you have a personalized antecedent. For example, stress is your trigger. You train a behavioral choice, and then you train from the dominant choice to an alternative that is relevant for your own health goals. So, in conclusion, biased decision-making is important in addiction and can be improved by combining therapy and targeted cognitive training, CBM. It's effective as add-on to regular abstinence-oriented inpatient therapy, approximately 10% relapse, 1 year later, a reduction. And I think we have some ideas to improve this.
Fantastic. Thank you so much. That was really brilliant sort of overview of where we're at with CVM. We've probably got time for one very quick question. Everybody's ready with one? Anyone? No? Well, we might come back to you at the end if that's okay, Reinout.
Sure.
There's further questions. Yeah. Thank you so much. We shall move on now to who's next. David, are you? Can you get your share screen ready? So Associate Professor David Pennington is from the Department of Psychiatry at University of California, San Francisco. He's a clinical research psychologist and the Associate Director of Addiction Research Program at the San Francisco Veteran Affairs Healthcare System. And his research program focuses on developing new digital health interventions and investigating their associated underlying neurobiological mechanisms to help improve the treatment of alcohol and substance use disorders among underserved veterans with common co-occurring conditions. He's received numerous awards and he's currently investigating neurochemical changes after approach bias modification and examining virtual reality working memory retraining to enhance cognitive function among patients with TBI. Please welcome David.
Great, thank you. Can you hear me okay?
Yep.
Perfect. All right. And it looks like my slides are up. I'm going to jump into this. Got a lot to cover and I'll be talking a little quickly. So, if questions come up, just jot them down and we'll go over them at the end. So thank you for having me. So today I'm really going to be talking about a recently finished pilot clinical study looking at working memory training using virtual reality in veterans with alcohol use disorder and traumatic brain injury. And just a real sort of brief background, why brain injury? So we study novel interventions for veterans with TBI and alcohol use disorder because TBI is really the signature injury of modern conflicts, and most of my work is done at the Veterans Affairs Hospital in San Francisco. So in the US, about 11 to 23% of deployed military members have sustained a TBI, and since the year 2000, there have been about 414 documented cases of TBI, the majority of which are mild in nature. Now, among US veterans with TBI, approximately 80% have a co-occurring psychiatric disorder. So, and as many as 60% have significant problems with alcohol or other substances. So therefore, really examining new treatments for AUD in isolation discounts the potential confounding effects of TBI and also really limits the generalizability of findings for this large population of veterans with TBI who are seeking treatment at our VA system. Now, I'm not going to go into detail about the mechanisms underlying alcohol use disorder and TBI, but they do overlap, and they affect key regions underlying executive control. So given that these problems are potentially worsened by having both conditions, it's really important to study if current new treatment approaches are efficacious in populations where they co-occur. So similar to approach bias modification, working memory really can be a training that it can be another augment or an adjunctive treatment. And working memory really refers to the ability to retain information in memory for further use in a flexible way that really allows it to be prioritized, modified, and protected from interference. Now, working memory is considered this foundational executive function. It's important for adequate representation of things like self-regulatory goals, control of attention, and protecting goals from outside interference so you could achieve those goals. Now, in the last 10 years, there's been a lot of rehabilitative efforts focused on improving executive function. Sorry, I'm getting some feedback there. Partly this is due to advances in computerized training methods. But although there have been many computerized working memory retraining paradigms, there's still a lot that needs to be learned before this type of intervention, I think, can be widely disseminated. For example, there's lots of gaps regarding the number and breadth of training sessions necessary to produce an effect. There's also practical issues that need to be addressed. For instance, working memory training is long, laborious, it raises issues around compliance. And finally, we don't really know the full extent to which this type of training generalizes to other behaviors besides cognitive performance. Now, VR technology has emerged as a real innovative therapeutic training tool with numerous applications in healthcare settings. It creates this immersive simulated environment with these really rich interactive experiences designed to be appealing to the user. And then just sort of as a shift gear slightly here, we also know that aerobic exercise is beneficial for those in addiction treatment. It's sort of a forgotten component of addiction treatment. But we know it can improve mood, promote healthy neurovascular function, and it's been shown to improve working memory in individuals with TBI. So based on this line of reasoning, we thought that combining exercise with working memory training in an immersive VR environment could help address some of the training issues surrounding compliance, breadth, and generalizability of working memory training alone. So, like I said, we recently finished a small 8-week randomized crossover study to examine the effects of VR-based working memory training combined with exercise compared to either exercise alone or random gameplay alone. Now, this was primarily a proof of concept study, but we were hopeful that we would also be able to at least establish a signal for efficacy in improving not only just working memory, but other associated cognitive functions. And we assessed a broad range. I think our neurocognitive assessment battery was about an hour and a half and covered things like not just working memory, but visual scanning, cognitive flexibility, inhibition switching, auditory, verbal learning and recall, visual spatial learning and recall, and motor impulsivity. We also assessed some general health outcomes: alcohol craving, alcohol use, and traumatic brain injury symptoms. This is, I don't know if you could see my pointer, but this is just a brief overview of the design. So after baseline assessment, 30 participants in total were split into 2 groups. 15 were randomized into the iPad game session condition, which consisted of 9 sessions of 30-minute gameplay over the course of 3 weeks. And the other 15 were randomized into an exercise-only condition. This was, again, 9-session, 30 minutes over the course of 3 weeks. Then we had a brief washout period of 1 week where participants did not play games or exercise, followed with an assessment, a follow-up assessment at the end of that period. And then both groups crossed over into the active, so the exercise plus VR working memory training sessions. And again, this was 9 30-minute sessions for 3 weeks with an 8-week follow-up period. And again, a 12-week follow-up period, which I'm not going to talk about for brevity. Our VR game station really consisted of this Schwinn recumbent bicycle. We chose a recumbent bike because a lot of our patients have balance and gait issues to begin with, so we wanted something that was safe. The game station had these 2 controllers. We partnered with a company called Blue Goji, who had been working on developing an active game station, so they let us use their program that they were working on developing, as well as their controls. And we used an Oculus Rift headset. Now, the Oculus Rift at the time was sort of the best thing on the market for the particular price point, but you also had to have a powerful gaming station, laptop, and numerous sensors. And I'll talk a little bit about why that's important in a second. So we chose Blue Goji's Going Safari, and we'll see if this plays. This is a path-based adventure game where the user explores wildlife environment. So we chose a game that tried to target attentional. See if this is playing here. But we tried to choose a game that targeted various components of working memory, including attentional scanning, divided attention, and motor responsivity. But basically, the user moves through this virtual environment by pedaling the stationary bike. As the character moves through the environment, they need to scan the environment and target animals and press a button to take the animal's picture. Or if they see a poacher, they're to alternate between camera and a net blaster, target the poacher and press a button to capture the poacher. Now, the faster they pedal, the faster they can move through the path, and each environment includes different collectible rewards, and other engaging game features. At the end of the session, the user receives feedback, a score, distance traveled, and the photographs that they took. Now, see if there we go. Now, in terms of retention, we had a difficult time. So we only had 21 of the total 30 complete phase 1. 4 were lost to follow-up, and a big chunk of the study was being conducted as COVID began. So we actually had to withdraw 4 participants from our phase 1 component of our study due to COVID, and then an additional person relocated. Out of the 21 who completed phase 1, those who were randomized to bike completed about 7 sessions, those to iPad about 7.5 sessions. Now, out of the 21 that started phase 2, we only had 15 complete phase 2. So that would be 15 who completed the total study. Now, 4 in the phase 2 were withdrawn because of COVID. 2 were lost to follow up. And out of those who completed, they completed about 6 VR training sessions. In terms of feasibility or usability, we administered the system usability scale. And on average, we had a score of about 70, which is actually the lowest score possible for an acceptable usability rating. And this really equates to an okay system. The biggest criticism on our system was that it needs a lot of support, a lot of technical support to be set up, and people didn't feel confident that they could do it on their own. But even though the usability was somewhat low, the client satisfaction was high. Out of a 32-point scale, our average satisfaction was a 31, and most people said they would refer a friend to our VR training program if they were interested. Exercise was actually rated as being the most helpful, so just the exercise condition only, followed by VR plus the working memory VR training plus exercise, and finally last by iPad, the gameplay. All 15 said that they would recommend trying this to their friends. 10 of the 15 said it helped them feel mentally better and physically better. 7 of the 15 said they drank less. 3 of the 15 said they quit drinking, and 3 said they had no changes. Some of the criticism and dislikes were the majority, overall the majority said nothing was harmful, but 3 out of the 15 said they did experience dizziness and motion sickness, or the VR technology didn't work consistently. And they gave us lots of tips on how we could improve the controllers, the game speed, and other various VR technology issues. In regards to outcome, a little bit of a spoiler alert here, but what we saw overall is that during the first phase of the study, we actually saw some pretty large improvements on a number of cognitive domains related to either the iPad condition alone, which we didn't expect, or the bike condition alone. And so by the time we had our washout period, we really didn't see enough, or we didn't design enough time within our washout period to sort of reduce that effect to really examine what was going on in VR. So although the baseline for bike and iPad was not different than the week 4 baseline of VR, what we did see is a significant improvement in the iPad condition arm on visual spatial recall, but not in the other 2 conditions. The same was true for visual scanning. And then for cognitive inhibition, we actually saw a significant improvement in the exercise-only condition of the arm. And although it was no change, we did see numerical decreases in the VR working memory condition of the arm. Actually, the only place where we saw a direct impact on working memory was during phase 2, where we saw that the number of calories that one burned per session was actually associated with greater change in working memory. Now, again, this was only during phase 2. We didn't see the same thing during phase 1, where they were still riding the bike, but not doing the cognitive training. And in regards to alcohol craving, we saw similar effects, reductions in the biking condition only as compared to iPad and VR. No changes, again, in our combined exercise and VR condition. And same thing with alcohol. And really, this sort of points out this our poor washout design, where we just saw these really significant reductions in alcohol use associated with exercise, not enough time for that to rebound or change, and then just continued low levels for the VR plus working memory condition. So in sum, enrollment into this type of a study was feasible, but there's a lot of room for improvement, particularly in the use of more modern and usable technology. COVID-19 really impacted our phase 2 retention. We lost 8 total subjects, which we think we could have retained during that time. They were pretty engaged in the study. And this really speaks to sort of the scalability of interventions like this, something that could potentially be done in the home versus in the lab, or where we did it, which was in a physical therapy lab. The effects of phase 1 were really not sufficiently washed out for proper evaluation of phase 2. So study design on a subsequent study like this needs to be altered. And then on the flip side of that, even though it wasn't what we wanted to see, we did really see some strong effects of exercise on cognitive function, alcohol use, and craving. And although not necessarily specific to our working memory training, we did see at least that signal for the combined working memory training plus exercise have an effect on change in working memory scores. So where are we going for the future? Well, it really is about scalability and improvements in VR technology. In the current market, there is an Oculus Quest, which does not require a gaming PC. It doesn't require lots of setup. There's no sensors, and it's made for a user to basically just put on and play. So for future studies, we'd like to incorporate this type of headset. A larger trial should also focus on specific cognitive domains for retraining. We sort of chose a game that Blugoji had that we thought mapped onto some domains, but we want to be more specific in what we're targeting going forward. And these VR paradigms really need to, I believe, need to incorporate physical activity, but attempt to reduce some of the motion sickness that's involved with VR. And just to, as example, in our game, there's a lot of up and down movement, which really was associated with the motion sickness and the dizziness. And to speak to that, we've been talking with another company called Virtue Leap, and they've come out with they've been working on developing a VR cognitive training paradigm called Enhance. This paradigm, or this environment, really focuses on specific cognitive domains, including planning and organization. I don't know if the video is playing well for you all, but essentially, the user would go into this environment. They would choose which particular domains they would want to work on, or they would be assigned these domains. They would practice doing these various games over the course of every day. They could do this within the home. They don't have to come into the lab, as long as we would supply them a VR headset. And they could track their progress over time to see how much they improve. And they get user feedback at the end of the training, showing how much they've improved and in which domains they can continue to improve. So we're excited to continue talking with Virtue Leap, hopefully develop something for the future. And being a startup company, they actually reached out to us and have been very open about receiving feedback about how we can improve what they've already begun developing. And I think with that, that's about it. Just want to shout out to everybody in our respective labs and also our funding sources. This was funded by a small pilot study in a UCSF Academic Senate Award. And with that, I'll take questions.
Thank you so much, David. I think we might have to hold questions until maybe a bit later on, because we have 2 more speakers, but that was absolutely brilliant. It's such an ambitious but groundbreaking study, and I really appreciate your candid report on, some of the challenges you faced in the design and some of the findings. I think some really useful tips and considerations there for anybody else considering such a brave move in terms of combining working memory training using VR and whilst exercising. That's absolutely brilliant. Thank you.
Sure.
So we'll move on to Hamid now, but hopefully we'll come back and we'll have time for questions if you can stick around, David. Yeah? Okay, so moving on to the next speaker. Dr. Hamid Ekhtiari is an associate investigator and director of the Neuroscience Informed Interventions Prediction Medicine lab at the Laureate Institute for Brain Research. He received his medical doctorate degree from Tehran University and his PhD in neuroimaging in 2015. His research focuses on using fMRI and brain stimulation in order to reshape the future of psychiatry and addiction medicine. Welcome, Hamid.
Okay, hello everyone. It's just great kind of pleasure and delight to be here and kind of discuss about such an interesting topic. I already kind of wrote a long list of different things that people have been discussing, and I think that we will have lots of things to discuss together, how we can move forward in this field. So let me just get started, as we are a little bit behind the schedule today. So what I'm going to talk, first of all, I need to kind of thank my colleagues and collaborators that made all these things that we are going to discuss today possible for us, especially Martin Paulus, Robin Opperly, Tara, who is already with us here, Brad Collins, Mohsen, and Naim. Okay, so you probably have heard that we have developed what we call a sort of classic neuropsychological rehabilitation program for drug users in around 2014, 2015. And in that specific program that we call Brain Gym, to be kind of easier for people who are in the field of substance use disorder to understand, we use different sort of cognitive domains with classic neuropsychological training tasks with targeting attention, visual spatial processing, working memory, verbal skills, executive functions. And we ran that in 16 sessions. As you can see here, the exercises are graded. So we started from the simpler exercises towards kind of more complex and more kind of harder exercises that people had to do in the trial. And it was a part of Dr. Rezapour's PhD thesis, and now she's a kind of faculty member at Institute for Cognitive Science in Tehran. So we have kind of recruited 120 subjects in two kind of groups, and the other control group were receiving painting classes instead of the active neuropsychological rehabilitation that we were providing. So we have published the results. So I'm not going to discuss about the details of that specific trial, and we show that we have significant difference in terms of the number of positive urine drug tests, in terms of kind of lower urine drug tests among those who have been receiving the active intervention. But what we have learned from that trial that basically helped us to move forward for the next steps, we realized that these neuropsychological rehabilitation could be very engaging. So we have been receiving lots of feedbacks in terms of, okay, how can we have more homeworks, and how we might be able to have probably more exercises when we kind of giving people homeworks. And we have been pretty much successful in showing that it could also have far transfer effect in terms of the positive urine drug test. But the other thing that we realized that it's really important that how we basically implant the cognitive rehabilitation program into the treatment and as usual, and how we can provide motivation for those who are attending the program. And I think that is what we have kind of heard about that from other speakers in this panel, in terms of how much motivation is going to be important, and also the treatment context. In this specific trial, we have recruited people from a residential center, and their program was not really intensive, so they had lots of free time. And when we were providing these sort of brain games for these people, they have been really receptive for that. So they really liked that, and they had time to do those exercises. And they had sort of competitions because we ran that in a group setting. So they really liked that. And I think that's the reason that we have been pretty much successful in that specific trial. So that might be something that we can discuss, how these minor details could be really important in terms of how these sort of cognitive rehabilitation trials could be effective or not. And then from that point, we have to start to think about how we can move forward and understand about brain targets that we are engaging in these specific trials. And as Dr. Aklin has mentioned, that is something that we are trying to understand in terms of the mechanism of these cognitive improvements, and meanwhile, not only cognitive improvements, but also how we can help people to have better treatment outcomes. So these are, as you can see here under the slides, these are the domains that we have been targeting, but we have been thinking, okay, how we can move forward and think about the specific brain imaging paradigms that could engage brain neural circuits that are involved in drug addiction. So we move forward to develop what we call Brain Gym 2.0. And the Brain Gym 2.0, we have started to think about, okay, how we can bring in drug cues to the paradigms that we have. So we started from that point thinking about how we can include drug cues. And for the drug cues, as you know, there is a specific kind of what we call a kind of drug cue reactivity paradigm that we compare drug cues compared to controlled neutral cues, that they have same visual spatial features without having the kind of the balance of drug use. And there are something like more than 300 fMRI drug cue reactivity studies right now in the field. And it's something like a kind of well-developed field. So as Reinout has mentioned, people have used these sort of fMRI drug cue reactivity trials or paradigms or tasks to test the efficacy of different interventions, including cognitive trainings or cognitive rehabilitation. So we developed what we call a database of meth and opioid cue database, because we realized that there is no publicly available fMRI task that people can use easily in the field. So we developed a large-scale database with 360 images that includes both meth images and opioid images and control images. And this database is already available. So we have recently published the entire database. And not only the entire database, but also 6 different fMRI tasks that are designed to be equivalent to each other. So 3 for meth, 3 for opioid. So you can use these 3 fMRI tasks for test, retest. Meanwhile, the drug cues are distinct between these 3 sets of fMRI tasks. So you use different drug cues, but all these drug cues are controlled in terms of their psychophysics features and also their psychological features in terms of the valence, arousal. So we have developed an intensive sort of kind of database. Those who knows basically the PNAS or IAPS database, this is really close in terms of the structure of the database. So we provide every single details in terms of the valence, arousal, craving, typicality, those things that are important for drug cues. So from that point, we have started to kind of develop some sort of trying to see how we can have biomarkers from fMRI drug cue reactivity to see, okay, how we can engage these biomarkers. So this is, as you can see here, we can kind of activate different neural circuits in terms of when you expose people to these drug cues. And if I want to show you an overview about different areas that in the brain that are involved, as you can see here, this is the prefrontal cortex, temporal cortex, what we have in the parietal cortex. So different parts of the brain are involved, and these are basically the subcortical areas. And in this kind of way of kind of measuring the activations in different parts of the brain, we can think about, okay, it seems that there are different sort of cognitive functions that are involved when they expose people to drug cues. And there's always a really important question about reliability of these markers. And as Reinout has mentioned, that it's really important to have an idea about when you want to use a specific measure, how much these measures are really reliable and how we can use them to test the target engagement. We have done a test-retest reliability testing. That is probably one of the first studies that people have tried to do test-retest reliability for an fMRI drug cue reactivity task. And we have shown that there are areas that they have ICC over 0.5, which is really good for the field of task-based fMRI. And that is, as you can see here, that's the kind of the graph that shows different parts, different areas in the brain. And there are areas that you can see that they pass the 0.5 threshold in that small sort of, we had just 22 subjects for that test-retest reliability, but we are extending that trial. Meanwhile, in terms of the replication, how much these markers are going to be replicated in different samples. So we had an initial discovery sample among meth users. We moved to another database, which is in total different, another clinical center with different kind of levels of kind of abstinence. And we have shown that, for example, the reactivity of ventromedial prefrontal cortex to drug cues, which, as you can see here, there is a sort of habituation response, could be replicated in sample 1, sample 2, we had another sample. These two samples are met users, but these samples are opioid users. As you can see here, the pattern is the same. But interestingly, when we did a test-retest on the replication sample 2, you can see here when we have the habituation of the drug cue reactivity effect, the effect would not survive in the kind of retest. And that would make things really complex and also interesting in terms of, okay, when we use a specific drug cue reactivity, how can we get sure that these drug cue reactivities would be useful for test-retest when we want to measure the target engagement in a specific, let's say, cognitive training or cognitive rehabilitation trial. We have the manuscript is under review, but we put the preprint on bioRxiv, so those who are interested, they can find the details in the bioRxiv. And from that point, we have to start to think about, okay, how can we move forward and develop a specific intervention to engage some of these biomarkers that we have with fMRI drug cue reactivity. We developed a model that is about how drug cues could activate drug-seeking behavior. And let me just show you another kind of figure that might make it easier for people to understand in terms of how kind of specific triggers in the environment could engage attention, memory, saliency processing, interoception, and control, and then finally the response in terms of drug use or abstinence. And from this model, we move forward and we develop another, this is basically the Brain Gym 2.0 that we developed that has 16 sessions of different sorts of interventions. And we have received the fund from Oklahoma Center for Advancement of Science and Technology. And even for developing the cartoons inside this new setting, because we have started to have the trial in an addiction treatment center for women. So we changed all the characters to feminine characters, and we even ran a study in terms of asking people to see which kind of female character would be more engaging. And also we have been interested to have a character which would be to some extent race neutral. So we move forward and we realize that character 2 is more engaging, and we develop cartoons for character 2. And as you can see here, we have those cartoons for women. So we try to kind of design the entire package for women. And we have recently put together the protocol in PsychArchive, so those who are interested to have the details about the protocol and have how we have designed this package, you can find the details there. Okay, but the last part of the things I'm going to discuss about today is about what we have been discussing today in terms of the motivation. And motivation, specifically motivation for cognitive rehabilitation or cognitive training interventions. We realize that it's really important for people who are going to get involved in these sort of cognitive rehabilitation trials to give them an idea about, okay, how your brain is affected by drugs and how there might be hopes for having better brain functions using these sort of cognitive training or cognitive exercises. So we realize that that level of metacognition is going to be critically important to engage people and also have better results in cognitive training programs. So for that idea, we have started to develop or think about how we can provide people with a level of psychoeducation in terms of, okay, how your brain is affected by drugs and how the things that we are providing in terms of the cognitive training would be helpful for you in terms of your overall recovery process. So we have been thinking about how we can find specific cognitive domains that are affected by drugs. You know that there are different models right now from NIDA, NIAAA. People have to try to develop different models. So we move forward with a combination of what we have from the Quaco model and the RDoC model. So we combine them together to reach to a specific model for different cognitive domains that are involved in drug addiction. And we try to summarize them in 10 major domains, as you can see here in the slide. And from that, we move forward to basically develop psychoeducational materials for these 10 major domains of cognitive function that are involved in drug addiction, and give people an idea about how these specific cognitive functions are affected and how they might get improved in the process of cognitive training. So as you can see, yeah, just probably 2-3 slides, yeah. So that is the kind of the overview that we have for the kind of psychoeducation material. So we developed them in 4 sessions, Now we have them in 4 sessions, 90 minutes each. We put together a feasibility study, so you can find the feasibility study on medRxiv. And we have been always open for those who are interested to have these materials. So we already have them in 13 different languages. So those who are interested, they can have them in other languages. Right now, we are moving forward with the web-based version of the package. So we are working on the web-based version. And we have developed some corona-related kind of interventions to that. So we already have that one as well. As you can see here, there are specific things regarding in the same framework, but about corona. And we added them to the package with some specific corona-related tips. So those who are interested to have those materials, they are available in the kind of our institute website, in the BARI page. There are videos about them, and just the last slide, some take-home notes. I think that the cognitive rehabilitation could be engaging and feasible, at least what we have learned during last 5-6 years of working in the field. The treatment context is extremely important. I can discuss about that, how we are being challenged when we want to kind of implement what we already have in the treatment context that are not really receptive to what we are providing. Then how we might be able to have target engagement in the cognitive training exercises, and how fMRI drug curatively could be a really good model as something like a mechanistic biomarker, and what are the advantages of using this specific mechanistic biomarker. In motivation is going to be critically important. I think that the metacognition and psychoeducation is going to be critically important. And I think there are definitely potentials for international collaborations. Okay, so I try to remain in the time frame, and I'm open for discussion.
Thank you, Hamid. I think we might have to move on and leave some time for questions at the end, if that's okay. We've just got, we're going to hear from Antonio on goal management training, and then we'll get into the discussion. So are you okay to hold some questions until then?
Absolutely.
Yeah, great. Thank you. Sorry for my poor timekeeping. So Antonio, I'm sure, is no stranger to most of you here. He is a professor in the School of Psychological Sciences in the Turner Institute for Brain and Mental Health at Monash. He is an Australian Medical Research Future Fund, or MRFF fellow, and a co-chair of the ISAM NIG. His research focuses on the cognitive and neural mechanisms underpinning executive control and decision-making in substance abuse and behavioural addictions, where he has published over 200 peer-reviewed articles and attracted over 10,000 citations. Go for it, Antonio. The floor is yours.
Thank you very much, Vic, and thank you, everyone. Let's see how... Oops, that's a bad start. Here you go. Let's see how well I can do at 6 in the morning. So I wanted to chat a little bit about goal management training in stimulant addiction, and I'm going to try to be brief. And then I'm going to make a proposal for the next steps in this collaboration that we want the ISAM Neuroscience Interest Group to be, and I will open the discussion to the floor. So a couple of pieces of evidence to understand a little bit more why we became interested in goal management training. This is work that we did back in the day. Actually, I cannot remember when we did it, but it was a while ago. And it was a very comprehensive neuropsych assessment of people with substance use disorders that we were presenting into therapeutic communities. And we were trying to estimate the degree of clinically significant impairment that we could see in these patients. From the very beginning, we saw that one of the areas that was more heavily impacted was executive function. If you look into specific components, like in this table here, the classic model in which you have working memory, inhibition, and shifting, you can see that there is a significant proportion of people presenting into this type of treatment services that have a clinical level of executive function impairment, and it's across the board. It's in the different elements of executive function. The other thing that we found interesting at the time is that when we directly compared people with cocaine addiction and people with heroin addiction, for some of the executive components, especially for inhibition and cognitive flexibility, we found that the people with stimulant addiction were significantly more impaired than the people with opiate addiction, which was kind of surprising at that time. The other interesting piece of evidence is that executive dysfunction predicts clinical outcome in people enrolled in addiction treatment. And we have shown these a number of times, and we have shown it for different executive components again. So this is a number of longitudinal studies in which we were measuring different components of executive function at baseline, and then we were following up people and taking a little bit of a sample of their hair, and then analyzing the toxicology in the hair to see if they had relapsed and to what extent they had relapsed. And we have observed in independent studies, replicated also overseas, that working memory, decision making, not so much response inhibition, but definitely delay discounting predictors, longitudinal predictors of drug relapse. Sometimes, like, we have tried to obtain different phenotypes, for example, of decision making, and we have seen, for example, that of course there are individual differences, and you have some people that have intact decision making, but interestingly, those are the ones that are more likely to remain abstinent after 3 months. Then we have some people with some reinforcement learning problems, which are to be expected in the majority of the addiction population, and this one had a higher likelihood of relapsing. And then we have some people that had real trouble making decisions and a real insensitivity to the future outcomes of their decisions. And in these patients, you can see that almost 90% of them had relapsed after 3 months. So that means that people with stimulant addiction have significant executive impairment, and these impairments longitudinally predict how they are at risk of relapse in the long term. So you can imagine how we thought that it would be interesting to shop around and see if there was some cognitive remediation or cognitive rehabilitation program that could try to improve or strengthen executive functions. And at that time, we found this program called Management Training that was developed between Cambridge and Toronto. And then it was copyrighted by Baycrest. The original author is Brian Levine, and he very kindly agreed to, so that we could see here the main modules of the program as we originally applied it. So you could see that it had 7 different modules, and each of them could be done over 1 or 2 sessions. So it's a quite intensive program, but you can see, and that's what my circles were trying to represent, how it targets some of the key executive problems that we were discussing before. So things like the sleep apps or problems with response inhibition, problems maintaining your goal in working memory that David has beautifully described before, problems making decisions, or problems shifting between different tasks and organizing when they have to multitask and have to check their performance. So we took goal management training and we applied it. I think let's say that the good thing is that it is a manualized intervention, so you can do it you can implement it in a very straightforward way. So we did it the first time back in 2011, and we did it in an outpatient community center. We combined it with a little bit more intensive mindfulness exercise. And then we did it again a couple of years later in a therapeutic community environment. So in both cases, essentially what we were doing is applying GMT on top of treatment as usual and comparing GMT plus treatment as usual with the treatment as usual per se. And you can see on the right side of the slide some of the cognitive outcomes that we found had improved after applying goal management training. So we found significant improvement in response inhibition, decision making. In the second study, we found out that actually, like, partly the improvement in decision making was driven by a more careful, a more mindful approach to gathering information before making a decision, which is measured by the information sampling task, which is the one that you see at the bottom So with all these knowledge, when I moved to Australia, from the very beginning, I wanted to apply goal management training in people with methamphetamine addiction. But I guess like from the very beginning, we also realized that maybe we were going to have to do some changes. One of the key changes is that the program was too long and too intense. The mean treatment episode for people with stimulant addiction in Australia is something like 28 days. So it was very difficult to fit 7 modules in less than 1 month. So we thought that we had to try to capture the essence and make an abbreviated version of that. And the other thing is that obviously the goal management training was originally developed for people with brain injury. And although there's a lot of overlap between the cognitive impairment in both conditions, as David was highlighting before as well, some of the materials were obviously not tailored to people with stimulant use disorders. And then is when I found these 2 amazing students, Alex Anderson, Alex Robinson, who started to work with me, and other Monash collaborators, Eden Potter and Daphne, that are part of a group that is called Health Collab, that is specialized on designing interventions cater for the individual or cater for the population that you are dealing with. And we started this project of trying to co-design a repackaged version, a revamped version of goal management training. So you can see, I'm not sure if you're familiar with the original program, but I can tell you that didn't have this type of characters and animation. So this is a little bit Aussie. This is a footy fan, like celebrating one of the goals of his team. And but I think the important part of the slide is in here. This is the way that we decided to abbreviate the modules. So we decided to shorten the program and just distill the essence of 4 main modules, which are the one that is dedicated to increasing awareness, the one that is dedicated to response inhibition with the ability to pause and think, the ability to shield your goals and protect your goals in the working memory, and the ability to make better decisions. So the way it works, and this is an interesting discussion maybe for later, goal management training is a combination of practice and strategy learning. So in each of these modules, we're going to have a very specific practice that is targeting a mechanism. For example, in the Be Aware, we're going to be targeting mindfulness. In the Stop, we're going to be targeting response inhibition. Here, we're going to be targeting working memory and practicing it. And here, we're going to practice how to make long-term decisions. But at the same time, what we aspire to achieve is that participants also develop strategy learning around the whole strategy. And that means that every time they have to face an important decision or they have to face a difficult situation in their lives, they are likely to apply the whole strategy. So they're likely to be a little bit more aware. They're likely to control some of the immediate responses that come about, get back to their goals and make better decisions. So we train each of the individual parts and also the whole cycle. These are some examples of the different modules. So here you can see a little bit of the things that we discussed in the first module about being aware. We have adapted some of the tasks. So this is an adaptation of the original stop signal task that people trained in the original program. In this case, they are a bouncer in a club and they have to identify when David is trying to sneak into the club and then like stop from pressing the buzzer. And then we use we've been testing a number of analogies and a number of visualizations so that they understand concepts like working memory, which is very familiar for many of us, but very difficult to understand for some, I would say for any other layman person. So we used analogies like, for example, this one here in which you're trying to protect like that goal that you have in working memory, but of course it can be sensitive to the tide and it can disappear. So you have to make a conscious effort to try to keep it up and try to work with that goal in your day-to-day decision making. We have also introduced some novel aspects and some technology. So at the moment we are trialing practice with episodic future thinking, which is a prospection technique that allows you to visualize how you would be in the future and how you can infuse that with some positive affectivity and a sense of agency. And we are reproducing, like we're using virtual reality to reproduce the Kokoda walk, which is a very popular walk in Melbourne. People call it 1,000 steps. We thought that it was a very nice environment to put the participants on and try to work with their goals and try to work with their episodic future thinking. And we have developed a number of visualizations that can help people to make better decisions. So here you can see a visualization of how to split tasks into different actions to achieve a final goal. We have developed a journal. This was called homework in the original GMT, but we call it a journal now, which is something that participants keep and use to practice every day. And they also let us know how they're feeling and how are they using some of the strategies that we propose on a day-to-day basis. And the idea is that the more you practice, the more you're going to be able to automatize that full cycle of goal management training. Here are some of the activities that we've been doing also to practice different skills. We use this really cool activity to try to promote working memory. Essentially, they have to build poems and they have to keep the keywords in their working memory, and they have to strike through all the other stuff that is not relevant. And the other thing that we're doing is we're create something that can work as a cue when they finish the program. So you can see here the bracelet that they're building to work as something that is always going to remind them of the GMT strategy at the end of the day. So the idea is to use this type of approach that uses both training, practice, and strategy learning to try to restore some of the cognitive deficits that we observed at the beginning of my career. I'm very happy to have moved from just describing deficits into going to try to do something to improve them. And that's it. I just wanted to acknowledge especially the students, Alex, and the different sources of funding. Some of our collaborators, including Dal Lapman, Vic Manning, Arnaud Brousseau, that is dealing with the virtual reality. So a lot of good people involved in these studies. And maybe what I can do is just a little bit of advertising of my book in case you don't know about it. Like, this is a very good opportunity to do some free advertising. But maybe what I can do without a pause is to make a little bit of a proposal of what is the plan that we have, that we envisage to move this area forward, and just open the debate to the audience to see whether they think this is a good plan, whether they want to be involved. So the idea that we have is, as you have seen today, there is a number of beautiful research initiatives across the world that are trying different cognitive training and remediation interventions. But when it comes to grants, or when it comes to trying to implement the interventions in clinical services, or even when it comes to discussions with colleagues, as Vic was putting at the very beginning, there is a certain skepticism about cognitive training and remediation and what is that we can achieve through these. And I think one of the reasons is that we haven't done a good job in trying to, let's say, like, package everything we have in a way that it can be observed as best practice standards. So what we are envisaging is to create this Delphi consensus in which, there is a whole team of experts that try to make some decisions and get to some agreements about what are the best approaches for strengthening cognition in the context of addiction treatment. And the consensus could be on different things, and we have lined up some of the domains that we would like to get agreement on. Like, one are the mechanistic targets, and one of the questions that we have is which type of taxonomy do we use to survey people in terms of what are these mechanistic targets. Another one is what are the key approaches? Do we use computerized training? Do we use old-style remediation? Do we use cognitive rehabilitation? We just adapt traditional interventions to make sense of cognitive deficits. And then some of the key components of the interventions and some of the key components of the delivery mode that can help us to maximize the effect that we can achieve on behavior change, which is kind of closing the circle that Will started at the beginning of the webinar. So this is up to debate, and it's kind of a starting point for maybe getting some thoughts and some opinions on whether this is a good idea, how people see this plan, and what other aspects do they think we should be promoting. So that's it. Thank you very much.
Thanks, Antonio. That was brilliant. It's a beautiful illustration of goal management training there, and I'm really looking forward to seeing the results of it being introduced into practice here in Melbourne and other parts of the world. So yeah, let's open up this time now for some discussion around what Antonio has just proposed there. We're really keen to hear your thoughts. So feel free to unmute yourselves and chip in.
It's going to be great. Those who are going to kind of actively get engaged in the Delphi proposal, just turn on their videos to be able to kind of start the discussions, and we probably can just kind of move forward with discussions if you kind of turn on your videos as well. And I take this opportunity to thank Victoria and Antonio for putting together such a nice kind of panel and such a nice webinar together. I've been observing that they have been working together for kind of several weeks, getting sure that it's going to be done in the perfect way. So thank you very much for kind of Antonio and Victoria for putting this together. So that was a really great job.
Thank you very much, guys. But it's been a pleasure, honestly.
So if we could just ask people to identify that I can't see anybody, unfortunately, but if you can just say who you are and where you're working, if you wish to add to the discussion, that'd be great.
Yes, the first thing to know from you guys is whether you think this is a good idea to start with, because maybe it's a terrible idea. I mean, it's 6 in the morning. Like, you cannot expect a lot from me, so just let me know. And I guess the second part of that is, how do we shape it up? And if it's not a good idea, then what would be another avenue? And whether you share some of our concerns in terms of, like, this field has been a little bit stagnated somehow and not moving in a cohesive direction. And whether there is other ways to promote that.
Sure, I'm happy to kick start the discussion. My name's Jamie Berry. I'm a clinical neuropsychologist in private practice. So I've come to this area from a clinician's perspective, but I've become increasingly involved in research in this space over the last 7 years or so. And I think it's a wonderful idea, Antonio. I'm particularly concerned about measurement, especially measurement of executive function. So from a clinical perspective, one of the problems is it's hard to reliably assess executive functioning. And there are also concerns about validity of traditional neurocognitive tests of executive functioning when it comes to real-world functioning. So I'm certainly happy to be involved and to make a particular contribution in that space. I think it's all well and good to break down the executive functions into their kind of traditional components, as you have, working memory and shifting and inhibition. But I think if our goal is to affect real-world changes in real people, then I think we need to think a little bit more broadly about how to assess those changes where the rubber hits the road. So, yeah, wonderful initiative.
Thank you very much, Amy. And actually, it's been one of the things that we've been discussing these days as well, like measurement in terms of characterizing performance, but also in terms of characterizing changes and characterizing the active mechanisms of the interventions that we are interested in applying. So I think it's a key aspect. And one of the questions that we had is, if we are to develop this consensus, which taxonomy should we be using? We previously did a Delphi consensus on assessment, and we used the RDoC framework. But sometimes the RDoC framework can be confusing when you try to translate it in the typical domains that we use in neuropsych assessment. So we're not confident on whether it's a perfect fit or not. So we are more than open to suggestions about what other taxonomies we could be using. Go, Reinout. You have to unmute yourself. No, not yet.
Hi everybody. I'm Salvatore Campanella from Brussels in Belgium. I have maybe two main comments or questions, I don't know. My first question would be, what's your thought about biomarkers? Do you think that maybe you can use them to create maybe some kind of subgroups of patients and to orient these patients to some kinds of specific retrainings? And the second one is also, what is your idea on the fact that maybe it could be more useful or more relevant to combine cognitive retraining with some kind of TDCS or stimulation or etc.? So these are more comments or questions or remarks, I don't know, but maybe it's useful to discuss about them.
Yeah. And Salvatore, you should tell us what they are, but but I'm happy to take them as questions. And actually, like, they're very well put, because Hamid and Valentina are going to be working on some on the biomarker space, and this is going to be one of the next challenges for the NIG group. So maybe Hamid and Valentina can speak a little bit on that, if you're happy to.
Yeah, definitely. We will have, we are planning for the next ISAM NIG webinar in September on discussing about basically why we do not have any FDA approved biomarker in the field of addiction medicine. Because you know that we do not have any biomarker, any sort of neuroscience, especially neuroscience informed biomarker in the field of addiction medicine. So nothing is basically received the level of qualification to be approved by FDA so far. And we can discuss what would be the pathway to have any sort of neural or cognitive biomarker that could be used in the field to develop new interventions and test different interventions. So that is a big challenge in the field. And I think that we will have lots of really nice discussions in that specific webinar, discussing about what are the quality standards for that and how we can work together to develop those biomarkers.
I wonder if we can have a series of Delphis, right? Like just also based on this debate on the stage, so that, for example, after today, we're a little bit clear about cognitive bias modification, cognitive training, and that can inform a little bit what the framework could be and other aspects of cognitive training, and then a separate one more on biomarkers that could be also informed a little bit by the discussion about biomarkers specifically. I also wonder whether the RDoC approach versus other approaches are something that we can actually include in the Delphi itself. So just to really map a little bit about the heterogeneity between experts in the field in terms of what do we think works, and it doesn't have to be a black and white approach either. Another suggestion is that perhaps there's also another method that apparently is called multi-component decision analysis. I don't know if others are familiar with it, but apparently it's like Delphi, but a little bit more weighted and objectives more, so it comes with actual values and weighting. So perhaps that is something as well that we can think about of using just to make this work impactful and this consensus work impactful as well. But I think it's a great idea.
I think these are excellent suggestions. Reinout, I think like now you got the sound. No.
No. Ryan, can you unmute? Reinout?
Come on, Reinout. It's only the evening there.
I hope he can get it working, because I was hoping he could speak to the combining of cognitive training interventions and brain stimulation. I know he's been involved in some studies, the Donnell studies.
That is that is an interesting topic. You know that we have another network that is called International Network of TMS, TES trials in addiction medicine. It's called INTOM, and we have 50 labs that are doing brain stimulation in the field of addiction medicine, and there are definitely labs that are interested in trying to combine them together. I think that one of the major challenges is that we really don't know how these two different sort of interventions are working so far. And when you combine them together, you would basically add the level of complexity in terms of how these things are going to work together. There are definitely lots of really interesting models about, okay, how we can combine them together, how we can increase the top-down regulation with combining brain stimulation and cognitive training. And there are models supporting that when you basically add cognitive training to the brain stimulation, then the effect might be synergistic. So they can basically synergistically support each other. But the challenge is that sometimes, I think that the field of kind of brain stimulation in the field of addiction medicine is, in my understanding, is in a chaos. To some extent, people are doing different things. It's really hard to see any replication in the field, and that is a bit challenging. So I'm hopeful that there would be interesting kind of potentials, but meanwhile we can understand that there are definitely lots of complexities when we merge these things together, especially when we don't really know how kind of each individual of these interventions are working.
To build off of that a little bit, this is Justin Strickland from Johns Hopkins. The thinking of Jamie's point about measurement in a kind of the dependent variable sense, this was touched on in I think many of the talks today, but the idea of creating more harmonization across these different procedures. If you are not familiar with this literature, trying to figure out how cognitive bias modification is done, attentional bias modification is done, you'll read 5 papers and get 5 different representations of how to do it. So, I mean, we have these many great examples of effective or at least efficacious implementations of these procedures, but harmonizing them so that we're all doing the same thing and we can combine them on the back end.
Yeah, that'd be good.
That's also something else that we can discuss in the Delphi, right? I suppose there might be also researchers who might have different views. For example, some groups might, think that there is a more sensitive measure, and that's the measure, someone else. And so maybe that's also something that we can tap into to understand what is the consensus around that. And so what does the majority of experts think as well? I suppose there's so much heterogeneity that the whole goal of the consensus would be really map what is different and where to go. And also if there's 2 different school of thoughts and that's what comes out, just publishing something like that would be informative so that, research can choose something wide, right?
Then there are 2 school of thoughts to test against one another instead of 8 school of thoughts that are here and here and here and in reality kind of thing
here. Yeah. I can see Reinout trying to speak.
I know. Do you hear me now?
Now, perfect. Yeah.
Yeah, you can hear me?
Now I can hear you. Yeah. Go for it.
It was too late for my microphone, I guess. Yeah, so actually, what I want to come back to is your very first question, I think, about the taxonomies, because I think that is really important. And what I think is really, I think in a very simple way, really, but in a way you have goals which are really central. And that's what I really like also about the goal management training. It's conceptually related to our new view on cognitive bias modification in the ABC training, where also the goal is central and that should be personalized. And all these more general tools, they're very good to train them, but they should be in function of a personal goal. I really think that's the key thing when you go to clinical applications. And from that, so in terms of taxonomy, I wouldn't only focus on what specific, how we carve up the brain and which tools we have, but more like the central thing should be the goal, which is related to motivation, alternative behaviors to achieve that goal, etc. And then you have all these tools. It could be working memory training, but working memory training without a relationship to that goal is not going to help, as many studies have shown. You know, you have all these generalization problems. So I really think we should reshape this whole area in terms of goal management, basically. So starting from the goals, and then the rest is really tools to help people achieve these goals. And then, you know, we can look whether it works better with virtual reality or computerized or face-to-face, and what predicts what works better for whom, etc., etc. But to me, goals of the patient are central, and they should be first influenced, and the rest is helping them to achieve them.
Mm-hmm. Absolutely.
I just wanted to echo what Reinout has mentioned, and I think that I'm highly recommending the commentary that Reinout has written in Biological Psychiatry CNI, what he showed us, the graph that he provided, and that specific kind of commentary. And I think that he has done a really nice job in terms of for suggesting a sort of taxonomy or kind of categorization of these sort of interventions. And I think that we have been discussing with Antonio and Victoria in terms of that is something that we need in the field in terms of making a consensus about what would be the best terminologies to describe the field, what are the different taxonomies that we can have in the field, and agreeing on those taxonomies to get sure that what we are discussing about, we are all on the same page. And then we will use those terminologies and taxonomies in the future studies to get sure that we are talking about the same map and we are all discussing about the same map, and then we can move forward with the same map together.
Yeah, I think it's really what we try to influence is intentional behavior. So looking at it without looking what people's intentions are or what their goals are, you know, you're kind of missing the central point.
I think it's a super interesting idea, and it makes me wonder if I would love to go that way in addition to the more traditional way, but I was wondering if that's the case, whether we should be surveying patients directly, and whether that could be something that we could collaboratively do together, because obviously each of us maybe have access to a limited pool of participants, but maybe if we do it together, we can get a very international representative sample that can tell us a little bit more about what are the goals that these people aspire to achieve. And in parallel, we can get some consensus on what the experts think could be good ways of addressing those goals from a cognitive training remediation approach.
And I think what you're doing already with the goal management and making that in a shorter version, that's a really great approach. And some of those training efforts could actually be part of that. So I see it more as an organizing principle.
What is going to be also important in terms of when we talk about kind of goals of the patients, the reality is some of those patients, they do not have a really good level of metacognition about what is the problem that they have. And interestingly, when we ran that kind of psychoeducation, neuroscience informed psychoeducation package, we tested people with their self-reports of, let's say, attention deficits, memory deficits, and it's significantly higher post-intervention. So they reported after something like 1 month of intervention, we had significantly higher self-report of attention deficit, memory deficit, kind of control deficits, because we have been providing with an understanding about what do we mean by control, what do we mean by attention, why attention is important. So sometimes it's also important to understand that, patients might not have a clear understanding about what are the brain rehabilitation goals that they can pursue.
Totally agree. So it's part of the program, I think, is developing goals. So yeah, you shouldn't expect to get a clear-cut goals from the very start.
That's correct, and I'd like to add that very much reflects a clinical neuropsychological intervention approach. I could easily spend 3 sessions with a client face to face, just working out what the goal is, and I wouldn't proceed with any neuropsychological intervention unless I've got those goals. So then the intervention hangs off those person-centered goals. And I think that raises another issue that we may have to contend with. And I think one is it sounds like the group is happy to move towards a kind of person-centered approach, but then that raises the challenge of the reductionistic goals of this process in terms of delineating the building blocks. So I think that's going to be an ongoing, interesting question to resolve.
The more I hear from you guys, it seems like we're going to need a pre-Delphi before the Delphi. Like we're going to have to survey a little bit more like opinions within this group. And maybe that's something tangible that we can get out of these. If you're interested in like creating the shape of the final, we call it Delphi, we call it a different thing, like can be a whole program, let us know. And maybe we can start a discussion that hopefully lead us into something that is already a pre-agreement on what we think it's going to be a powerful approach.
Yep, sounds good.
Yeah. So the next steps, Antonio, I mean, is it worth us trying to organise a subsequent webinar that looks at this in more detail, perhaps with, you know, I'm sorry we didn't get to have more time for discussion and questions today, but I'm wondering the next sort of best step would be to maybe organise that in a month or two, or do you think it's best done through?
I think we can organize a group discussion. It doesn't have to be in the form of a webinar, but maybe we can have some correspondence and then lead up into a group discussion. Definitely, please, not 6 in the morning, not 5 in the morning.
That's the problem.
and we can go from there. But what I would say is everybody that has attended today and is interested in participating in this process, please email us to the ISAM NIG email so that we know what are the forces that we have and we can start to organize that.
Yeah, what we can do, I would ask Pernyon to put the ISAM NIG email on the chat space so people can find the ISAM NIG. We have already invited some of the people that we have here. I can see kind of people like Marco Persino. I mean, there are lots of really kind of great figures in the field right now in the discussions. And we have Javier right now here. I mean, there are many people here that we can definitely work together and build up the taxonomy and the process. So Pernyon is going to put that kind of a specific message in the chat space. So those who are interested, just send an email to ISAM NIG that we are interested to contribute in that Delphi that Antonio is leading. So we kind of try to get sure that we'll have an expert panel within the ISAM NIG, and hopefully Antonio and Victoria move forward with the kind of putting that together. So we are hopeful within the ISAM NIG that each of these webinars would end up to have to a specific consensus to be able to harmonize what is happening. Right now, we have kind of comments from people in Africa that they are interested to contribute to that, and even how we can think about co-designing or thinking about the kind of minor cultural kind of things that we need to consider in different parts of the world. So there are definitely lots of potentials for making consensus together in the field.
Thank you, Hamid. That's beautifully summarised there. That's our intention, and I'm really looking forward to having the opportunity to work with you all. Thank you so much for attending today. Huge thanks to the speakers, to Will, Reinout, Antonio, David, and Hamid. Thank you all for attending. And if you haven't already joined the Neuroscience Interest Group, please do. There's 4 sort of subgroups, one on assessment, one on cognitive training, one on imaging, and one on stimulation. And yeah, we'll look forward to seeing you at the next one. Thanks very much.
Thank you, Vic. Thank you, Vic, for chairing.
Thank you. Yeah, thanks.
Thanks, everybody.
Bye.
Good.